factors related to precancer and cancer lesions of the cervix in Tanzania, and it was about relating socio-demographic factors and symptomatic factors to women who are presenting with precancerous lesions and cancerous lesions of the cervix. So a little bit about cervical cancer incidence and mortality. About 35 to 40% of women in Tanzania have cervical cancer, and 55 to 60% of them usually die from the disease. So it's pretty serious, as you can see. So a little bit about what is a precancerous lesion or a cervical intraepithelial neoplasia. It's also known as a cervical dysplasia, and there's 3 levels. There's CIN1, CIN2, and CIN3. And obviously, as it progresses, it becomes more serious. But the good news is that cervical intraepithelial neoplasias are completely curable, and they can be cured with something as easy as cryotherapy. And on the screen here, we can see this is a normal cervix, but as you progress through the disease, you can have more mitotic figures, and it gets more serious. So what is early stage cervical cancer, and what is it characterized by? So for early stage cervical cancer, the lesion is not more than 3 millimeters deep and 7 millimeters wide. But for stage 1-2 or 1A, you have it as 5 millimeters deep and 7 millimeters wide. But if you move on to stage 2, you'll have it invading just beyond the pelvic wall. But stage 3 and stage 4 cervical cancer is where it gets more serious, because for stage 3, it starts blocking the ureters, and it can actually mess up with kidney function, and that's a condition called hydronephrosis. And then for stage 4, you can see it metastasizing to other places like the bladder, the rectum, and that's when it seriously intervenes with life. And it can sometimes be seen in the bone as well. So a little bit about ORCI. ORCI is located along the Indian Ocean, and it's the only cancer facility or specialized cancer treatment in Tanzania. It offers cervical cancer screening, breast cancer screening, and a lot of great services for its patients. Over here you have me with our on-site mentor, Dr. Masami, who is great and helped me out with all my projects. Over here you have the main building, which is Block D, where we got our medical records. And here is me in the pathology lab shadowing the pathologist, which was a great opportunity we got to do. So the aim and objective of my study was to create an epidemiological and clinical profile of patients presenting with cervical intraepithelial neoplasias, early stage cervical cancer, and late stage cervical cancer. So in total, there was about 225 cases for cervical intraepithelial neoplasias, 743 cases for early stage cervical cancer, and 349 cases for late stage cervical cancer. So my study design was a retrospective cohort. In total, we collected demographic information, infection information for precancerous lesions. Late stage cervical cancer, we collected demographics and symptoms, as well as for early stage cervical cancer. And this was provided from Lindsay, who was able to give me her data. So for cervical cancer, there was about 33% who were late stage cervical cancer, and early stage cervical cancer was about 67%. And then for precancerous lesions, there was 81% who were CIN1, and then 19% who were CIN2 or 3. So this was actually pretty great because they were diagnosed earlier more than in later stages. So in terms of demographics, I collected information about age, occupation, education, and number of parodies, right? So for age, we can actually see that women who came in with precancerous lesions, they tended to be younger, around 26 to 35, while women with early and late stage cervical cancer tended to be much older, usually in the 46 to 65 age range. And then women, in terms of education, women with precancerous lesions, they tended to have higher educations other than primary school. So they tended to go to secondary school. So the gray is the precancerous lesions here. And it's definitely much higher than the early and late stage cervical cancer. And in terms of occupation, women with precancerous lesion, they definitely had better occupations. So a lot of the patients were listed as peasants, while other patients with precancerous lesions tended to be in business or in, working in an office. And then in terms of number of parodies, women with precancerous lesions tended to have lesser children than women with early or late stage cervical cancer. In terms of region of residence, Tanzania is a pretty big country, and sometimes it takes a while to get from place to place. So women with precancerous lesions tended to come from Dar es Salaam, where ORCI is, while women with early stage and late stage cervical cancer actually came from different areas such as Mwanza, Arusha, Mbeya, Dodoma, and some of these take almost like a day or two to travel to Dar es Salaam too. And lastly, in terms of symptomatic presentation for my results, a lot of early stage and late stage cervical cancer patients came in with pelvic bleeding and discharge because that is an important symptom related to cervical cancer. But more late stage cervical cancer patients came in with more serious symptoms such as constipation, lower limb pain, and lower limb edema. And that makes sense because it means the cancer has progressed. And then on examination, late-stage cervical cancer patients were found to be in worse conditions, so they were more pale, weak, and cachexic. And then some interesting points is that women who were diagnosed with precancerous lesions, they were found to have higher education than women who presented with early and later stage cervical cancer, and that women who came into the screening clinic with precancerous lesions were more likely to be younger with fewer parities and from DAR. And higher earning jobs were more prevalent with women with precancerous lesions as well. So some strengths of this project is there were significant differences in education, occupation, and region of residence of women presenting with CINs, early and late stage cervical cancer, and that this data can be used for further studies to track cervical intraepithelial neoplasia patients at ORCI. And some limitations, as mentioned before, is that there was a lack of continuity in medical records and EMR, and lack of staging information in some records. So future studies and implications. I think it could be really interesting if later on C student took my data and actually followed up with the precancerous lesions and saw if they developed cervical cancer afterwards. And in terms of like translation to immigrant populations, because I am a medical student and I will be seeing patients soon, we can see how sociodemographic factors such as occupation, education, and region of residence can really affect cancer presentation. So it wasn't all work. We had a lot of fun. We went to Bongoyo Island, which was beautiful. We got to sit by the water and enjoy ourselves a little bit. We went to Zanzibar. We had our coconuts, and we stood by the door. We actually visited different hospitals as a shadowing experience there. We got to see a rural hospital and an urban hospital and see the different services they provide. And lastly, I just want to acknowledge a few people. I want to acknowledge Dr. Solomon for being a great mentor and helping us with everything. Dr. Masami for guiding us on how and where to get medical records in Tanzania. Dr. Solar and the CHASM department for allowing this to happen. Mac Lipkin Fellowship for funding, and Lindsay for being the best big sister there. And yeah, any questions?